Bioresorbable scaffolds were meant to do their job and pretty much disappear over time. They were developed to improve long-term outcomes after coronary interventions, but a paper in the October 27th issue of JACC reports results that, well, as an accompanying commentary notes, you may be forgiven a feeling of déjà vu. Very late scaffold thrombosis, intracoronary imaging, histopathological and spectroscopy findings, and I'm with Dr. Lorenz Raber, who is an MD, a PhD, and from the University Hospital in Bern, Switzerland. First off, before we talk about the paper proper, tell us about the origins.
Well, thank you, Rick, for the invitation. Newer generation metallic drug-eluting stents have shown to dramatically reduce the risk for late occurring events, particularly for late restenosis and late stent thrombosis, yet they still occur at approximately 0.2 to 0.3% per year, and there seems to be an ongoing risk even beyond 5 years. Now, bioresorbable scaffolds have been designed to completely resorb within a predictable time period, which is, according to animal studies and pivotal clinical trials, at about 3 years. And the hypothesis, of course, is to further reduce these very late complications, ischemic complications, as scaffold thrombosis or scaffold restenosis. And this is the very background of our study, a case series of 4 cases that have been imaged by intracoronary optical coherence tomography, which is a technique that provides high-resolution images of the scaffold or of the stent. We have to note that it is well known that the correlates of very late stent thrombosis in the metallic death era are well described. There are 2 large registries that have consistently shown that malapposition, uncoverage, and neoatherosclerosis are the correlates that seem to trigger thrombosis. And we were interested in getting to know whether the mechanism underlying scaffold thrombosis, and it's a fact that they can occur, whether these correlates are comparable to those observed in metallic death platforms.
So you took 4 cases that you knew there was a problem, and then you did some very careful examination.
So this is a prospective investigation at 3 tertiary centers, the Triemli Hospital in Zurich, the University Hospital of Barcelona, Manuel Sabaté's institution, and the University Hospital of Bern. During the time of the observation, approximately 170 scaffolds were implanted, and we followed them, and we could observe 3 very late scaffold thrombosis, 4 scaffold thrombosis, and in these 4 cases, we did perform optical coherence tomography right at the time of the clinical presentation with acute coronary syndrome, and we investigated histologically the thrombus that could be removed from the vessel and performed detailed thrombus and OCT analysis.
I mean, I was shocked to see that polymer resorption may not be complete in humans as late as 4 years after device implantation. That was one of your findings. Did that surprise you?
Yes, this is actually a supplemental finding that has not been expected. So to tell you a little bit more about this case, this was a patient receiving a bioresorbable scaffold, an absorb BVS in the left circumflex. 3.7 years later, he presented with acute STIMI, and we recanalized this vessel and could obtain a large amount of thrombus. We did send the thrombus to Michael Jolner's lab, and surprisingly enough, we could identify a foreign body. This foreign body we had the suspicion that this could be part of this initially implanted scaffold, and we performed, or a renowned lab performed, an infrared spectroscopic analysis of this thrombus specimen and compared the pattern with an absorbed BVS, and it was found to be consistent, suggesting that the resorption may take a little bit more than only 3 years.
And then I think it was in all 4 cases, malopposed and uncovered scaffold struts in direct contact with thrombus were found. That suggests kind of a potential trigger?
Yeah, I think this is actually the main finding of the study. We had made 3 main observations by the optical coherence tomography. First, we could confirm that malopposed scaffold struts and uncovered scaffold struts can be identified in the region of the thrombus, which suggests, of course, a correlate between the two. The second finding is even of more interest. The second finding was the description of scaffold strut discontinuity. These are malaligned scaffold struts that are not embedded by neointima and can fall into the lumen and subsequently trigger thrombosis. It has to be noted that scaffold strut disintegrity has to be understood like the natural consequence of a scaffold that is resorbing. It loses its configuration, but usually these scaffold struts are then fixed by neointima and nothing can happen. And actually in the pivotal clinical trial, 40% of the scaffolds were found to be discontinuous. So this is not very summadal. But in our cases, we could observe that if these discontinuous struts are not embedded in the neointima, they fall into lumen and may trigger thrombosis.
Now, what does this mean for the technology? I mean, the whole idea has been to come up with something that disappears and causes fewer problems. Now, you only had 4 events in 173, was it? How many patients overall?
So, I think if anything, we can't conclude on the incidence. So this will be the most relevant research question that only can be addressed by large-scale randomized control trial like the ABSORB2, the ABSORB3, and the ABSORB4 trials. Our study does not allow any conclusion on the incidence, and therefore the clinical value of the findings is quite difficult to estimate. However, I think we can conclude that with this technology, we do need a perfect result immediately after implantation. The question is whether this has to be assisted by intracoronary imaging, at least to prove that we do a good job and that the patient can profit from this new and still promising technology. And it also suggests that some iterations of the technology are mandated, like the absorption time. I mean, we discussed that obviously sometimes there is a certain biological variability in the resorption, and exactly. if the scaffold takes 4 years to completely resorb, that is of course more worrisome than compared to a situation where we know it's gone within 1 year.
Well, congratulations, because this was quite an effort, and it is a very good paper. And you can find it in the October 27th issue of JACC. And for CardioSource World News and CardioSource World News Interventions, I'm Executive Editor Rick McGuire.